Welcome to The Clinical Signal, the podcast for leaders in post-acute and long-term care who want to understand what clinical screening technology means for their residents, their teams, and their facilities. It's April Parkinson's Awareness Month, and today we're talking about something that affects millions of Americans living in skilled nursing facilities right now, most of whom have never been properly screened for it. Because here's what most people don't know. Parkinson's disease changes your voice years before you ever shake. Stay with us.
Yeah, it really is just a profound paradigm shift.
Totally.
I mean, for centuries, right? Literally going back to when James Parkinson first wrote about the shaking palsy back in 1817.
Wow, 1817.
Yeah, we've been conditioned to look for the visible physical markers. You know, we wait for the hand to tremor or the posture to stoop.
Right.
But the clinical data we're looking at today shows us that we've been completely missing these invisible acoustic markers.
And the acoustic markers that have been broadcasting the problem for years.
Exactly. Broadcasting it completely undetected.
And that invisible acoustic broadcast is exactly what we're unpacking today in this deep dive.
Right.
Because we are spending this entire hour dissecting what is honestly an incredibly dense, totally fascinating stack of clinical research.
Oh, it's incredibly dense.
Yeah. Along with workflow documentation and platform specs centered around Shenza Health's GEEE platform.
It's just a massive leap forward.
It is. We're going to get into the raw science of vocal biomarkers and the computer vision algorithms, too.
Right, both sides of it.
And crucially for the facility operators listening, we're talking about the operational reality of deploying this in a building full of high acuity residents.
And as you mentioned in the opening, the timing of this discussion is very deliberate.
Right, April 2026.
Exactly. It's Parkinson's Awareness Month.
Yeah, and if you follow the Parkinson's Foundation, you know their theme this year is Join Together.
It's a great theme.
It really is. It's basically a call for collaboration across the entire continuum of care. You might have even seen the Spark the Night initiative happening globally right now.
Oh, the Spark the Night campaign is incredibly striking. I mean, seeing buildings and bridges.
Entire city skylines.
Yeah. Entire skylines illuminated in blue all over the world.
Just to show support for the estimated 11.8 million people living with Parkinson's globally.
It is a very literal visual representation of bringing a disease out of the shadows.
I love that framing, bringing it out of the shadows, because, you know, whether you're an administrator trying to keep your facility financially viable, or a director of nursing who's desperate to prevent your residents from declining, or just someone fascinated by the absolute frontiers of medical technology, understanding how we are pulling this disease out of the clinical shadows, it's going to fundamentally change how you listen to the people around you.
It really will.
Yeah.
I mean, if we pull back and look at the macro picture, what we're actually talking about today is this necessary evolution in our diagnostic senses.
Our diagnostic senses.
Yeah, because we rely so heavily on our eyes.
Yeah.
Right? We see the resting tremor in the hand. We see the shuffling gait.
We see the rigidity.
Exactly. But this research forces us to acknowledge that Parkinson's is an invisible disease first.
Wow.
It can be heard long, long before it's actually seen.
Okay, let's unpack this, because to really appreciate the solution here, we have to understand the sheer magnitude of the problem inside skilled nursing facilities right now.
The numbers are staggering.
They are a tidal wave. I mean, we currently have nearly 1 million Americans living with Parkinson's.
Right.
And the projections show that number heading straight toward 1.2 million by the year 2030.
Which is literally just 4 years away.
Exactly. And that aging demographic is going to land disproportionately in post-acute care.
Absolutely they are.
But here is where the data gets super weird. When you look at the official, documented, estimated prevalence of Parkinson's inside skilled nursing facilities, the SNFs, the number sits at about 5 to 7% of the resident population.
Right. And anyone who has spent significant time working on an SNF floor is going to look at that 5 to 7% figure and immediately recognize it as a massive underestimation.
A massive underestimation.
Oh, without a doubt.
Yeah.
Because that number, that 5 to 7%, that just represents the population that has a documented official diagnosis in their chart.
I see.
It absolutely does not reflect the actual prevalence of the disease walking around in the building.
Wait, so how much higher do you think the actual prevalence is? I mean, are we talking double that?
It could easily be double, perhaps even more in certain high acuity demographics.
Precisely.
Yes. Because spotting early Parkinson's in an older population, particularly in a skilled nursing environment, is just notoriously difficult.
Why is it so much harder there?
It's due to a phenomenon we call clinical masking.
Masking, like the symptoms are literally being hidden by something else.
Exactly. Just put yourself in the shoes of a floor nurse for a second. If a healthy 50-year-old walks into a clinic with a brand new tremor in their right hand, or suddenly starts walking with a stiff, slowed gait,
That's a huge red flag.
right, those are glaring, immediate red flags for any neurologist.
Sure.
But in an 82-year-old resident living in a SNF,
It's Tuesday.
exactly. Those exact same physical symptoms are often completely obscured by the veil of normal aging
Wow.
or heavily overlapping comorbidities.
Okay, let's unpack this with a real-world example. So if I'm picturing a typical resident, let's say Mrs. Davis in room 204.
Okay.
Davis, she had a minor stroke 3 years ago. She has severe osteoarthritis in her knees and, maybe some mild cognitive impairment.
Right, very typical profile.
If she starts moving slowly, no one is jumping to Parkinson.
Precisely. The clinical signal is just completely buried in the noise.
Yeah.
If Mrs. Davis is moving slowly and stiffly, the immediate assumption is just that her severe arthritis is acting up.
Or it's from the stroke.
Right, or it's a lingering deficit from her stroke.
Mm.
And if she has trouble communicating clearly, it's just attributed to the mild cognitive impairment.
That's so wild.
It is. The Parkinson's is actively destroying dopamine neurons in her brain, but the clinical staff is rationally attributing the outward signs of that destruction to conditions she already has.
So is spotting early Parkinson's in an SNF basically like trying to hear a single person whispering in the middle of a loud rock concert?
That is a perfect analogy. The music of all those other ailments is just drowning it out.
And to make your rock concert even louder and like more chaotic, you have to factor in the reality of polypharmacy in these facilities.
Oh, polypharmacy is a massive factor here.
I'm glad you brought that up because anyone running a facility knows the sheer volume of medications these residents take.
It's overwhelming.
Let's spend a minute on this. How exactly does polypharmacy mask a neurodegenerative disease?
Well, it basically creates this constant web of plausible deniability.
Plausible deniability.
Yeah. Let's say a CNA is helping a resident eat lunch and notices a slight resting tremor in the resident's jaw, or maybe their hand.
Okay.
The nurse reviews the chart. The resident is on a typical cocktail of medications, perhaps including a first-generation antipsychotic like Haldol,
Right.
or maybe an antiemetic like Reglan for nausea. Both of those drug classes are infamous for causing extrapyramidal symptoms.
Extrapyramidal symptoms meaning like drug-induced movement disorders.
Yes, they can cause tremors, rigidity, and slowed movements that look exactly like Parkinson's.
Oh, wow.
So the nurse sees the tremor, looks at the med list, and the immediate, completely logical clinical conclusion is this is a drug-induced tremor from the Reglan.
It's a built-in excuse for the symptom.
Exactly. Or if a resident is unusually lethargic and slow, it's blamed on a recently adjusted sedative. The polypharmacy just provides a convenient alternative explanation for almost every early Parkinson's symptom.
So the disease is just silently marching forward, the brain is changing, the dopamine is depleting. But everyone around the patient, the nurses, the doctors, the family, they're all attributing those changes to arthritis or old age or medication side effects.
Right. They're explaining it away.
So what is the operational and clinical fallout of that blindness? I mean, what actually happens to these residents when we miss this diagnosis for months or even years?
The fallout is catastrophic, frankly.
Really?
Yes. When Parkinson's goes undetected and unmanaged, the resident experiences a rapid, steep trajectory of functional decline.
Because they aren't getting the meds.
Right. Because they aren't getting dopamine replacement therapies, they lose their mobility much faster. They become rigid.
Which leads to falls.
A huge spike in falls. And as you know, in a skilled nursing facility, a fall with a major fracture is often the beginning of a terminal decline.
It's the absolute worst case scenario. And beyond the falls, the research really hammers home the risk of aspiration pneumonia.
Aspiration pneumonia is a major killer here.
That's essentially when food or liquid goes down the wrong pipe and directly into the lungs, right?
Yes. And it is frequently fatal in this specific population. Because Parkinson's doesn't just affect the muscles in your arms and legs.
Right.
It profoundly affects the muscles in your throat and your esophagus. It causes dysphagia, which is difficulty swallowing.
So the mechanics of eating just break down.
Exactly. The complex, highly coordinated sequence of muscles required to safely move food from the mouth to the stomach just breaks down.
But if we don't know that Parkinson's is there...
We don't know it's there, we aren't intervening.
Right.
The dietary staff isn't providing thickened liquids. They aren't doing mechanically soft diets.
Because they have no reason to.
Exactly. The speech-language pathologists aren't brought in to do swallow studies or teach compensatory swallowing techniques.
So they just try to drink water normally.
The resident tries to drink a simple glass of water. They aspirate. Bacteria from the oral cavity enter the lungs, and within 48 hours, they have a raging case of aspiration pneumonia.
Oh, man.
They end up in the ICU, and very often they do not come back.
And for you listening, if you are a facility operator or director of nursing, this connects directly to the absolute nightmare of state surveys and compliance.
Oh, from a compliance standpoint, it's a massive vulnerability.
Because a misdiagnosis isn't just a clinical tragedy, it is a massive failure in your care pipeline. The research specifically flags FTAG 605.
Right, FTAG 605, which governs nursing services.
Exactly. FTAG 605 explicitly mandates that facilities must have the competencies, the staff, and the protocols in place to accurately assess and respond to changes in a resident's condition.
Particularly neurological changes.
Right. So if a state surveyor pulls a chart after a resident is hospitalized for aspiration pneumonia,
Yeah.
and they see a 6-month history of subtle motor decline, unexplained weight loss, and slight tremors that were never properly investigated or assessed by a neurologist.
That is a massive liability.
Huge. You are effectively providing complex medical care in the dark.
And providing care in the dark is a very dangerous game, both legally and ethically. And that brings us to the core revelation in this stack of clinical research we're looking at today.
The acoustic window.
Exactly. We do not have to wait for the catastrophic fall. We do not have to wait for the aspiration pneumonia. Because before the hand ever shakes, before the gate ever shuffles, there is a window. An acoustic window.
Okay, this is the part of the documentation that completely hooked me.
It's fascinating.
The idea that the voice betrays the brain years before the body does.
It really does.
Can we walk through the physiological mechanics of this? Like, why is the voice this incredible early warning system for neurodegeneration?
Well, it really comes down to the sheer, staggering biological complexity of human speech.
Okay,
We talk all day, right? I mean, we take it completely for granted.
of course.
But producing even a single spoken word requires the flawless millisecond-level integration of 3 major physiological subsystems.
3 systems.
Yes. The respiratory system, the laryngeal system, and the articulatory system.
Okay, so the lungs pushing the air, the voice box vibrating, and the mouth shaping the sound.
Precisely. You need the diaphragm and lungs to provide the exact subglottal air pressure.
Right.
You need the tiny, delicate vocal folds in the larynx to tense, approximate, and vibrate at highly specific frequencies.
Okay.
And then you need the lips, the tongue, the jaw, and the soft palate, the articulators, to move with incredible speed and microscopic coordination.
Just to shape that vibrating air into recognizable consonants and vowels.
Exactly.
And how does Parkinson's disrupt that specific chain of events?
Well, Parkinson's is fundamentally a disease of motor control, right?
Yeah.
It's caused by the depletion of dopamine in the brain's basal ganglia.
Dopamine being the messenger.
Right. Dopamine is the chemical messenger that smooths out and coordinates all muscle movements. Now, think about the muscles involved in speech compared to the muscles in your thigh or your bicep.
They're tiny.
They're incredibly tiny, they are delicate, and they require hyper-precise, hyper-fast coordination. Because they demand such fine motor control, they are very often the first muscles to falter when that dopamine signal begins to degrade.
That makes total sense.
The neurological breakdown manifests in the larynx and the tongue years before it manifests in the large gross motor muscles of the arms or legs.
So the speech system is essentially the canary in the coal mine.
Exactly.
The research details 5 very specific vocal warning signs, these speech biomarkers that clinicians have identified over the years.
Right, the classic 5.
I really want to talk about how these actually sound rather than just listing them off. Let's start with hypophonia. What is the listener actually hearing?
So hypophonia translates to reduced vocal volume. But it's not just someone whispering on purpose.
Right.
It manifests as a soft, asthenic, or really breathy quality to the voice. The patient literally loses the physiological power behind their speech.
Because of the lungs?
Partly.
Yeah.
Because the respiratory drive is weakened by muscle rigidity, they can't push enough air.
Ah, I see.
And because the vocal folds aren't closing with sufficient force, air escapes, creating that breathy sound. The resident might constantly be asked to repeat themselves by nurses who just think the resident is speaking quietly.
That makes total sense. And then there's the monotone speech pattern. It's like the voice loses all of its emotional color.
Exactly. Normal human speech is incredibly dynamic, right?
Yeah, we go up and down.
Right. We intuitively raise our pitch at the end of a question. We get louder when we're excited or angry. Parkinson's strips that musicality away.
Because of the rigidity.
Yes. The laryngeal muscles become too rigid to make those rapid micro-adjustments in tension. That results in monopitch and monoloudness.
Wow.
The resident sounds flat, apathetic, or even robotic, even if they're feeling deeply emotional on the inside.
Which obviously could easily be mistaken for depression.
Oh, absolutely.
Which is another massive issue in SNFs. What about the articulation? The third sign is imprecise consonants.
Clinically, this is called hypokinetic dysarthria.
Hypokinetic dysarthria.
Yes. It sounds like slurred, mumbled, or indistinct speech. This is where the articulators, the tongue and lips, are suffering from bradykinesia.
Bradykinesia, which is the hallmark slowness of movement in Parkinson's.
Exactly. When you say a crisp consonant like a T, a P, or a K, your tongue or lips have to snap into a specific position and release instantly.
Right. It's a fast movement.
A Parkinsonian tongue simply cannot move fast enough to hit those targets accurately.
So the sounds just blur together.
Yes.
And I imagine that same bradykinesia is what causes the fourth sign, which is an overall reduced speech rate.
Yeah, the entire pacing of the conversation just drags.
Yeah.
The physical act of speaking becomes laborious, and the pauses between words and sentences lengthen significantly.
And the final warning sign is a voice tremor.
Right. Just like the hand can have a resting tremor, the laryngeal muscles can have a tremor.
Wow.
It creates an acoustic instability, a wavering or fluttering sound, particularly noticeable if you ask the patient to sustain a single vowel sound, like holding out an ooh.
So, hearing all of this, if I'm a director of nursing listening right now,
Yeah.
my absolute first instinct is to go tell my floor staff to start actively listening for breathy, monotone, slurred speech with a tremor.
Right. And what's fascinating here is that instinct, while completely understandable, is entirely wrong.
Wait, what?
It's wrong because you largely can't hear it.
We just spent 5 minutes describing exactly what it sounds like.
Right. We describe what it sounds like when the disease is already clinically obvious.
Oh, wow.
This is the crux of why this technology is revolutionary. The earliest stages of these vocal changes, the initial onset of hypophonia, the microtremors in the vocal folds.
The millisecond delays.
Exactly. The millisecond delays in consonant formation, they are entirely imperceptible to human hearing.
Seriously.
Human evolution did not equip our ears to detect a 2-millisecond delay in vocal onset time.
Wow.
By the time a nurse or a doctor can clearly hear the slurring or the monotone voice with their naked ear, a massive percentage of the brain's dopamine-producing neurons are already dead.
So human intuition and observation simply aren't enough.
They are completely inadequate for early detection.
Yeah.
It requires artificial intelligence.
It requires AI.
It requires sophisticated acoustic algorithms that can measure sound waves at a granular level that we cannot even comprehend.
And that brings us directly to the technology at the center of this research. Shenzi Health's JE platform.
Yes.
We're talking about capturing this data in a 40-second window, not a 40-minute clinical exam.
Right.
Just 40 seconds of casual, open-ended conversation.
It's a true paradigm of frictionless assessment. A resident just sits in front of a tablet and talks about their breakfast, or a memory from childhood, or their favorite TV show.
For less than a minute.
For less than a minute. And from that completely unstructured audio, the AI is extracting an incredibly dense, complex neurological profile.
Okay, let's unpack this. Let's really pop the hood on what exactly the AI is doing in those 40 seconds.
It's a lot.
It is doing deep math on the sound waves. The documentation states it tracks over 2,500 acoustic features in real time.
2,500.
I want to deconstruct a few of these specific biomarkers because it really illustrates the difference between human hearing and machine listening.
Okay.
First, let's look at fundamental frequency, or F0.
So fundamental frequency is essentially the baseline pitch of a person's voice, determined by how fast their vocal folds vibrate.
Right.
But the AI isn't just taking a snapshot of the pitch, it is meticulously tracking pitch stability and range over every single millisecond of that 40-second window.
Looking for the microscopic deviation.
Exactly. That creeping monotone effect we discussed.
Yeah.
A human might not notice it for years. The AI quantifies that exact loss of pitch variability with absolute mathematical precision from day one.
That is wild. Okay, then the research highlights two terms that I have to admit sound like a 1980s synth pop duo. Jitter and shimmer.
I always appreciate those terms.
They're great. What are we actually measuring there?
Jitter and shimmer are measures of vocal perturbation.
Meaning micro instabilities in the voice.
Yes. Let's use an analogy. Imagine a car engine idling. If the engine is perfectly tuned, it hums with a steady, perfectly spaced rhythm.
Right.
But if the timing belt is slightly off, the engine will have microscopic stutters.
The driver might not even feel a bump.
Exactly. The driver feels nothing. But a diagnostic computer plugged into the engine will absolutely register the erratic timing.
So jitter and shimmer are basically the diagnostic computer for the vocal folds.
Exactly. When you speak, your vocal folds vibrate hundreds of times per second. Jitter measures the cycle-to-cycle variations in the frequency of that vibration.
The timing.
The timing. And shimmer measures the cycle-to-cycle variations in the amplitude or the loudness of each vibration.
Wow.
If the AI detects elevated jitter and shimmer, it means the vocal folds are vibrating erratically. They are unstable.
And this is happening long before a human ear can detect a waver in the voice.
Long before, it is a direct, highly sensitive indication of impaired laryngeal motor control.
That engine analogy makes perfect sense. What about the harmonic to noise ratio, or H&R?
H&R evaluates the purity of the vocal tone. When we speak, the sound is a mix of pure periodic tones, the harmonics, and a teriodic sound, which is just acoustic noise.
Okay.
A healthy, strong voice has high harmonics and very low noise. A lower H&R suggests that the vocal folds aren't closing tightly or efficiently.
So air is leaking through.
Right. Air leaks through the gap during vibration, creating a noisy or breathy acoustic quality. The AI uses this ratio to quantify vocal effort and laryngeal inefficiency.
Incredible. Next on the breakdown are formant transitions and vocal onset time, or VOT.
This gets to the articulators, the tongue and lips. Formants are the resonant frequencies of your vocal tract.
So it's about the shape of the mouth.
Yes. Whenever you move your tongue or your jaw to form a specific vowel or consonant, you are physically changing the shape of your vocal tract.
Like changing the shape of a brass instrument.
Exactly, and therefore changing the formants. The AI tracks the exact speed and trajectory of those formant transitions.
And the vocal onset time? What's that?
Okay, say the word Parkinson's.
Parkinson.
When you form the P, your lips press together, stopping the airflow, and then pop open to release it. That's a stop consonant.
Right.
Vocal onset time is the tiny microscopic interval of time between the exact millisecond your lips pop open to release the P
Yeah.
and the exact millisecond your vocal folds begin vibrating to voice the R sound that follows.
Oh, wow.
In a healthy person, that timing is synchronized flawlessly by the brain. If the VOT is prolonged by even a few milliseconds, it reveals a profound laryngeal coordination delay.
The brain's dopamine depletion is causing it to struggle to sync the lips in the voice box.
Exactly.
That is crazy. And finally, the AI looks at spectral tilt.
Spectral tilt measures how the acoustic energy is distributed across different frequencies, high versus low.
Okay.
It's a highly sensitive indicator of vocal fold tension and the velocity of airflow. If the muscular tension is off due to motor control degradation, the spectral tilt shifts in a very specific, quantifiable pattern.
So the JAE platform is crunching these 2,500 variables, mapping the jitter, the shimmer, the VOT simultaneously in 40 seconds.
Yep.
The inevitable question from any clinician is, does this actually work in the real world?
And the data says yes.
Staggeringly, yes.
I am.
We are talking about an AI model validated on 12.3 million patient records across 19 clinical studies.
12.3 million.
And the accuracy metric they achieved for detecting Parkinson's is a 0.97 AUC.
Right. And for listeners who don't spend their days reading statistical methodology,
Which is most of us.
AUC stands for area under the curve. It's a metric used in machine learning and statistics to evaluate how well a model can distinguish between two classes.
In this context, accurately identifying someone with Parkinson's versus someone without it.
Exactly. An AUC of 0.5 is a coin toss. It's just random guessing.
Yep.
An AUC of 1.0 is clairvoyance. It's absolute perfection.
Wow.
Achieving an AUC of 0.97 on a screening tool is monumental,
It represents an incredibly high degree of clinical confidence.
especially when you consider it is detecting subtle, early-stage physiological changes that human specialists routinely miss.
Okay, so if the voice alone is this incredibly powerful diagnostic window, what happens when a resident isn't speaking much?
Good question.
Like, what if Mrs. Davis, the resident we talked about earlier, has severe expressive aphasia from her stroke and simply cannot participate in a 40-second conversation?
Right.
Does the AI just hit a wall? Or is the platform looking at other things?
That is exactly where the platform transcends just being a microphone.
Hmm.
While speech is a primary indicator, Parkinson's is fundamentally a movement disorder.
Right.
And the JEE platform doesn't close its eyes. This brings in the computer vision architecture of the system.
Let's break this down, because when I read this part of the research, I really had to wrap my head around it.
It's pretty sci-fi.
It is. We aren't talking about special infrared cameras or LiDAR scanners.
Yeah.
The AI is using the standard normal video camera on a typical tablet to analyze movement disorders. How is that possible? The first technique mentioned is Eulerian video magnification, or EVM, paired with GTSN models. Wait, back up. I know standard cameras just capture frames, right? Like 30 frames a second.
Right.
How is a normal tablet camera suddenly acting like a clinical microscope?
It is entirely computational.
Hmm.
Eulerian video magnification is just a fascinating piece of math.
Okay.
It takes a standard normal video feed and isolates incredibly subtle changes in the pixels over time,
Changes we can't see.
entirely invisible to the naked human eye. And it mathematically amplifies them.
Give me an example of how sensitive that actually is.
Okay, a classic example of EVM technology is taking a standard video of a person's face and amplifying the microscopic changes in skin color that happen as blood pumps through their capillaries with every single heartbeat.
Wait, really?
Yes. The algorithm can effectively read your pulse just by looking at the pixels of your face on a standard webcam.
That is wild.
It is. And in the context of Parkinson's, EVM is deployed to amplify subclinical tremors. If a resident's hand has a resting tremor that is so slight, so microscopic that a neurologist couldn't see it during a physical exam, EVM magnifies that micromovement.
So the algorithm can quantify the frequency and amplitude?
Exactly. And when they paired this magnified data with a global temporal difference shift network,
A GTSN model.
right, which is an AI designed to analyze motion over time, the accuracy for detecting resting tremors in the hands hits 90.6%.
That is clinical-grade tremor detection extracted from a basic video feed.
It's incredible.
Okay, what about the face itself? The research talks about using convolutional neural networks, or CNNs, to spot something called hypomemia.
Yes.
What is hypomemia, and how does a CNN see it?
Hypomania is the clinical term for facial masking. It is a hallmark symptom of Parkinson's, where the face loses its expressive mobility,
The person looks apathetic.
or like they are staring blankly. But not because they are depressed, but because the small muscles of the face are experiencing that same bradykinesia and rigidity.
And how does the AI detect that? Because a human doctor might notice someone looks blank, but that feels very, very subjective.
It is incredibly subjective for a human. But a convolutional neural network makes it objective.
How?
Think of a CNN, like a highly complex invisible grid that the AI places over the resident's face in the video frame.
Okay, a grid.
It maps dozens of facial landmarks, the corners of the mouth, the edges of the eyebrows, the contours of the cheeks.
Right.
The AI isn't subjectively looking at their smile. It is calculating the exact pixel distance between those landmarks, frame by frame,
Wow.
measuring how rigidly those pixels are locked in place over the course of the 40-second interaction,
So it objectively quantifies the exact degree of expression.
or lack thereof.
And the cameras is also tracking gross motor movements like gait and bradykinesia, right?
Yes, if a resident is walking in the frame of the video, the algorithms analyze their gait.
Looking for the characteristic shuffling.
The shuffling, the reduced arm swing, the hesitation when turning. They can also analyze standard neurological tasks like finger tapping.
Oh, like when a doctor asks you to tap your thumb and index finger together.
Rapidly, yes. A human observer with a stopwatch is just guessing at the degradation of speed.
Yeah.
The computer vision measures the exact velocity, amplitude, and rhythm of every single tap.
Here's where it gets really interesting. Because the real magic, the holy grail of this platform, according to the research, isn't just having world-class voice analysis or world-class video analysis independently.
No, it's sensor fusion.
Sensor fusion.
Sensor fusion is the critical breakthrough. Think about how the human brain actually processes the world.
We don't just listen in a vacuum.
And we don't just look in a vacuum. We integrate auditory and visual information simultaneously to understand context.
Right.
The GEE platform mimics that human integration.
Okay, let's unpack this, synthesize this for us. Mrs. Davis is sitting there chatting with the tablet for 40 seconds. What exactly is the AI pulling together at that exact simultaneous moment?
It is weaving an astonishingly dense web of multimodal data points, while the acoustic engine is crunching the 2,500 vocal biomarkers, the jitter, the shimmer, the VOT.
Yeah.
The computer vision engine is simultaneously tracking her microexpressions. It is calculating the pixel rigidity of her face. It is monitoring her blink rate.
Wait, why does blink rate matter in a Parkinson's screen?
Blink rate is actually a highly validated clinical indicator of central dopamine levels in the brain.
Really?
Yes. A significantly reduced spontaneous blink rate is deeply correlated with Parkinson's progression. The AI counts every blink automatically.
Wow.
Furthermore, it is measuring facial asymmetry.
To differentiate from a stroke.
Exactly. If one side of Mrs. Davis's face is drooping more than the other, the AI flags that, helping to differentiate between her past stroke and a new Parkinsonian pathology.
It is so smart.
It also measures postural sway, how much her torso wavers while she sits, which indicates core stability. And it tracks response latency, the exact milliseconds it takes for her to process a question and begin speaking, which is a marker of cognitive processing speed.
So it's capturing this massive, holistic, 360-degree neurological profile in real time. What does the clinical data say about the effectiveness of doing it this way, like using sensor fusion versus just using the voice or the vision independently?
The synergy is undeniable. The documentation points to a pivotal 2024 study published in the journal Digital Biomarkers.
Okay, the 2024 study.
This study demonstrated that utilizing multimodal sensor fusion, combining the acoustic features with the visual features, improved Parkinson's detection accuracy by 12 to 15% compared to using either modality alone.
A 12 to 15% improvement on a system that is already hitting a 0.97 AUC.
Right.
That is an enormous leap in clinical confidence.
It's massive.
Yeah.
Because in the clinical world, when entirely different physiological modalities converge in the exact same conclusion, the clinical signal becomes undeniable.
Right. If the acoustic data shows a prolonged vocal onset time suggesting a motor control issue,
And the visual data simultaneously detects a subclinical resting tremor and a reduced blink rate.
the physician receives a highly confident, multi-layered screening result.
Exactly.
Okay, let's bring this out of the realm of abstract AI research and ground it in the gritty reality of a nursing home. We need to paint a picture for you, the listener, of what this actually looks like in practice.
Because we all know what an S&F environment is like.
Yeah, it's not a pristine, silent laboratory.
Far from it, technology that requires perfect laboratory conditions is useless in post-acute care.
Right. We all know what a SNF common room sounds like at 2 p.m. on a Tuesday.
Oh, yeah.
There are TVs blaring the news, meal carts clattering down the tiled hallways, other residents talking, alarms beeping.
Constant noise.
Can this AI actually isolate the microtremor in a resident's voice when there's a bingo game happening 20 feet away?
That is where the noise cancellation and acoustic isolation algorithms really prove their worth. The system is designed for ambient clinical environments.
How does it do that?
It isolates the near-field audio of the resident speaking directly into the tablet and actively suppresses the far-field background noise of the carts and the TVs.
Okay, so set the scene for us. How does the interaction actually work?
The resident is sitting with a standard Samsung Galaxy tablet. On the screen is JEE, the digital human,
Okay.
and JEE initiates a conversation. It's important to note that JEE can speak to them in any of 92 different languages.
Which is massive for health equity, especially in diverse SNF populations where English might not be the resident's primary language.
Absolutely.
And finding a specialized bilingual neurologist is nearly impossible.
Exactly. So the resident is sitting there talking to this very lifelike, friendly digital human in their native language about their grandchildren or what they had for lunch.
It's just a casual 40-second chat.
A casual chat.
Uh-huh.
And the resident is completely unaware that they are undergoing one of the most rigorous neurological screenings on the planet.
Right, there are no wires attached to them.
No wires, there is no white coat anxiety, there is no intimidating clinical testing room, just a conversation.
Okay, I have to play the skeptic here. I want to push back hard on behalf of our listeners.
Please do.
Because if I am a SNF administrator, I am listening to this hypersensitive AI technology, and I'm thinking, what about the false positive?
The false positive question. Yes.
If this system is so sensitive that it's measuring millisecond delays and microscopic pixel shifts, aren't we going to get a massive influx of red flags?
It's a valid concern.
Are we going to unnecessarily terrify families and overwhelm our medical directors based on a 40-second iPad chat?
That is the single most important operational question a clinical leader should ask.
Okay.
And the answer requires a very firm structural establishment of boundaries. The JEE platform screens.
Right.
It does not diagnose.
Let's underline that. Screens, it does not diagnose. Explain the workflow difference there.
A screening tool is a radar sweep. It is designed to cast a wide net and identify potential hidden risk.
Okay.
A diagnostic tool is what confirms the disease. When JE flags a resident for high-risk Parkinson's indicators based on their voice and vision, no alarm bells go off in the hallway.
The tablet doesn't flash a warning.
No, the resident is not told they have a neurodegenerative disease. The family is not immediately called in a panic.
So where does all this incredibly dense data go?
Within 60 seconds of that casual conversation ending, the AI compiles a highly structured, objective clinical note.
And that note includes the risk scores, the specific acoustic biomarker findings, the tremor amplitudes, the facial masking metrics, all of it.
All of it. And that note drops directly and silently into the facility's electronic health record.
The EHR.
Whether the facility uses Epic, Cerner, Point-Click Care, Matrix Care, it integrates via API and lands directly in the physician's inbox.
So the human physician is always the final arbiter.
Always. The physician reviews the objective data provided by the AI. They cross-reference that AI data with the resident's medical history, their current polypharmacy load, and their own clinical observations.
So the AI is simply handing the physician a high-powered flashlight in a very dark room.
That's exactly it. The physician decides what they're looking at, and the physician decides if and when it is appropriate to initiate a formal diagnostic conversation with the resident and their family.
That makes total sense. It empowers the doctor, it doesn't replace them or circumvent their clinical judgment.
Never.
But let me push back with another very common clinical scenario.
Okay.
What if the resident already has a pre-existing condition that heavily alters their speech? Going back to Mrs. Davis, she had a severe stroke 2 years ago.
Right.
She already has significant dysarthria. Her speech is already slurred and slow. Isn't the AI just going to look at her slurred speech and immediately scream, "Parkinson's!" every single time she takes the screening?
This is where the architecture of the AI proves its true sophistication for long-term care.
How so?
The system is fundamentally designed around the concept of individual baselines.
Individual baselines. What does that mean in practice for Mrs. Davis?
It means that the AI does not compare Mrs. Davis's voice to a generalized global population average of what a healthy 82-year-old woman should sound like.
Because comparing her to a global average is useless.
Completely useless. When Mrs. Davis does her very first JG screening, the system spends those 40 seconds learning her specific voice.
It learns her.
It establishes her unique, personalized acoustic and visual baseline. That baseline explicitly encompasses her post-stroke dysarthria, her natural speaking cadence, and her unique pitch.
Oh, I see. So the baseline inherently absorbs her pre-existing conditions as her normal.
Exactly. And every subsequent screening she takes, whether it's next week, next month, or next year, is compared only against her own historical baseline.
The AI is looking for longitudinal changes from where she started.
Yes. If her post-stroke dysarthria remains stable over 6 months, the system raises no red flags.
Wow.
But if her pitch variability suddenly drops 15% from her own baseline, or her vocal onset time prolongs by 10 milliseconds compared to her first scan, the system flags it.
It tracks the delta, the change over time.
Yes. This completely bypasses the confounding variables of pre-existing conditions.
That is brilliant. It makes the tool clinically viable for literally every resident in the building, regardless of how complex their starting health status is.
It is the only way longitudinal monitoring actually works in a complex, multi-morbid, elderly population.
Okay, let's move to the final piece of the puzzle.
The bottom line.
Exactly. So what does this all mean? We've covered the underlying science, the AI mechanics, the workflow integration. But if you are running a post-acute facility, you operate in a reality governed by tight budgets, razor-thin margins, and incredibly complex reimbursement models.
That's the reality.
The science is amazing, but how do we pay for it?
Right.
What does this mean for the operational and financial reality of SNF leaders?
It means that improving clinical detection is not just a moral imperative. It is financially and operationally viable. In fact, it is revenue positive.
Revenue positive.
Yes. The documentation outlines specific existing mechanisms for how this integrates into revenue cycle management. Let's start with the immediate screening process. The use of the JEE platform aligns with existing CPT codes that facilities are already familiar with.
Anyone listening who deals with billing knows the headache of justifying new technology. What specific codes are we talking about?
The sources identify 3 key codes. First is CPT 96127,
96127.
which is a code for a brief emotional or behavioral assessment. This aligns perfectly with the initial AI screening phase.
Right.
Then, when the AI drops that data into the EHR and the human physician reviews the data and conducts their follow-up clinical evaluation, they utilize CPT 96116.
96116, the Comprehensive Neurobehavioral Status Exam.
Exactly. And of course, there's CPT 99309, which covers the standard SNF evaluation and management services for subsequent nursing facility care.
And from a diagnostic documentation standpoint, once the physician does confirm the diagnosis based on this early AI screening, we are looking at specific ICD-10 codes entering the chart, right?
Right.
Because anyone in medical coding knows the absolute mess of the R25 series.
Oh, it's notorious.
Trying to properly document abnormal movements when the residence chart is already a disaster of overlapping conditions.
Exactly. Accurate documentation driven by the AI's objective findings would bring in precise ICD-10 codes.
Like which ones?
You have G20 for primary Parkinson's disease. You potentially have G24.01 for drug-induced dystonia. If the AI helps the physician differentiate that the tremor is actually a side effect of that Reglan we talked about earlier.
Right.
And as you mentioned, there's the R25 series, R25.0 through R25.9, for documenting various abnormal involuntary movements.
And this is where the financial implications get incredibly real for a facility administrator, because capturing those specific high-acuity ICD-10 codes changes the entire reimbursement landscape for that resident.
It absolutely does.
The documentation provides a very specific ROI math scenario centered around the patient-driven payment model, or PDPM.
Yes. Let's run the math on this.
Okay, let's run the math, because when you map this onto a standard facility, the numbers are absolutely wild.
Okay, imagine a standard, average-sized 200-bed skilled nursing facility.
200 beds.
Based on the very conservative 5% undetected prevalence rate we discussed earlier, statistically speaking, there are at least 10 residents sitting in that building right now who have active Parkinson's disease but do not have the diagnosis in their chart.
10 residents out of 200. A highly conservative estimate, but a solid baseline.
Right. Now, because those 10 residents have an active, undocumented neurological condition, the facility is already spending the money and resources to provide higher acuity care.
Right. The nursing staff is managing their increased fall risk.
The dietary staff is modifying their meals for dysphagia. The CNAs are providing extra physical assistance for their rigidity.
The facility is spending the money, but they are not getting reimbursed for it because the diagnosis isn't officially coded.
Exactly. Under the PDPM framework, adding a high-acuity neurological diagnosis like Parkinson's to a resident's clinical profile impacts their daily reimbursement rate by an estimated $15 to $30 per day per resident.
$15 to $30 a day, which is designed to reflect the actual higher cost of the care that the facility is already delivering.
Exactly. It's not gaming the system. It's recovered revenue for work already being done.
So if we take that $15 to $30 a day, multiply it by those 10 previously undetected residents, and stretch that over a 365-day year,
The numbers add up fast.
we are looking at a financial impact of between $547,500 to over $1 million per year in recovered revenue for a single 200-bed facility.
Over $1 million in recovered rightful reimbursement.
Wow.
And that is purely from closing the documentation gap using a screening tool that requires zero nursing staff time to operate.
That's crazy.
The financial viability of the platform essentially pays for itself multiple times over, while radically elevating the standard of care and preventing those catastrophic FTAG 605 compliance failures.
But the clinical utility of the platform doesn't just end at the point of initial diagnosis. The research mentions one final, incredible clinical benefit regarding the ongoing long-term treatment of Parkinson's.
Yes, and this is crucial for the ongoing management of the disease, which is notoriously difficult.
Right.
A recent 2024 study published in the journal Movement Disorders validated that because digital speech platforms like JEE track longitudinal objective data, they can actually measure the acute, localized effects of pharmaceutical therapies.
Specifically levodopa.
Yes.
Levodopa is the gold standard medication for Parkinson's. It essentially crosses the blood-brain barrier and replaces the missing dopamine.
Correct. But dosing levodopa is an incredibly delicate tightrope walk.
Why is it so hard?
Because if the dose is too low, the Parkinson's symptoms, the rigidity, the slowness remain.
Sure.
If the dose is too high, or as the disease progresses and the therapeutic window narrows, the patient develops severe dyskinesia.
Dyskinesia, which are uncontrolled, erratic, writhing movements.
Exactly. Historically, adjusting the dose relied almost entirely on subjective observation. A doctor adjusts the dose, comes back a week later, and asks, "How are you feeling today, Mr. Jones? Do you seem a little less stiff? Are you moving better?
It's essentially clinical guesswork based on a brief observation.
Exactly. But with the JE platform,
With JE, the physician isn't guessing.
they have objective, quantified data. A physician can prescribe a new, adjusted dose of levodopa, have the resident do a quick 40-second screen an hour after taking the pill, and look at the exact percentage improvement.
Wow. Did their pitch variability increase by 12%?
Right. Did their vocal onset time shorten by 8 milliseconds? Did the amplitude of their resting tremor decrease by 40%?
The AI provides documented, irrefutable evidence of whether a specific pharmaceutical treatment is actually working optimally for that specific patient at that specific time.
That is true precision medicine,
Yeah.
delivered via a standard tablet in a skilled nursing facility.
Okay, finally, let's touch briefly on the operational logistics of rolling this out. Because $1 million ROI and precision medicine sound fantastic, but any administrator knows that IT implementations in healthcare can be absolute nightmares that drag on for months.
Oh, absolutely. But the platform specs are very clear on the deployment model, and it's built for rapid integration. First, as we established, it requires 0 clinical staff time to operate. The nurses do not have to administer the test. The digital human conducts the screening autonomously.
That's a huge burden lifted.
The platform itself is FDA 510(k) registered. From a data security standpoint, it is fully HyperREST compliant and SOC2 Type 2 compliant, ensuring the data architecture meets the highest enterprise security standards.
And what about the hardware itself?
It's deployed exclusively on NOx-certified Samsung devices, which guarantees military-grade, hardware-level encryption.
And from a project timeline perspective?
The documentation states that a facility can go from signing the contract to a fully integrated EHR deployment in just 2 to 6 weeks.
2 to 6 weeks, that's fast.
It's very fast. It is a rapid deployment, low-friction model designed specifically not to overburden already stretched facility IT departments.
It really is a remarkable convergence of acoustic science, computer vision, AI architecture, and practical operational design. We have covered an immense amount of ground in this hour.
We really have.
From the invisible epidemic of masked Parkinson's hiding in SNFs behind polypharmacy and comorbidities, to the granular reality of 2,500 biomarkers in a 40-second acoustic window.
The science is just incredible.
It is. We've explored the immense power of multimodal sensor fusion combining voice and vision, the critical safety net of physician-in-the-loop workflows, and the massive PDPM revenue implications for facility operators.
It really paints a vivid picture of a near future where we do not have to wait for a neurodegenerative disease to physically break a patient before we start treating them.
Right.
We can intervene while the disease is still just a whisper.
And as we wrap up this deep dive, I want to leave you, the listener, with a final provocative thought inspired by all this research.
Okay.
We've spent this entire hour talking about this technology operating strictly inside the clinical walls of a skilled nursing facility.
Right.
But think about the inevitable trajectory of this kind of AI. If an algorithm can detect the earliest microscopic whispers of neurodegeneration by analyzing the jitter, the shimmer, and the pixel rigidity of our face during a casual 40-second chat on a tablet,
Yeah.
what happens when this ambient technology inevitably moves beyond the clinical setting? What happens when these algorithms are integrated into our daily smartphones, or the smart speakers sitting on our kitchen counters, or the webcams we use for work meetings?
Wow.
Will our entire definition of healthy aging completely change when our own homes, our own devices know we are getting sick years before we ever feel a single physical symptom? It's a staggering, world-changing thought.
It represents the ultimate final shift from a reactive healthcare system that waits for failure to a truly proactive health awareness that catches the faintest signals of change.
That's the clinical signal for this week. If anything resonated today, visit scienzahealth.com/a-demo, not to buy anything, just to see what a 5-minute screening looks like. Subscribe on Apple Podcasts and Spotify. This is the clinical signal. We keep humans in the loop. Always.